A few months ago, Josh Vanderwerf gave us a brief history of American neurology.
This combination of publications, textbooks, organizations, and specialized hospitals and training programs over the course of time after the Civil War really helped form American neurology as a field and gave it recognition on an international level. During this grand age...
In that segment, Dr. Vanderwerf ascribed the origins of that movement out of the Gilded Age and of the American Civil War, where traumatic peripheral nerve injury was extensively investigated. 100 years later, another breakthrough in neurology would take place, but this would impact the field of central nervous system disorders as opposed to diseases affecting the peripheral nerves. Welcome back to BrainWaves. I'm Jim Siegler. Today on the show, Levodopa for idiopathic Parkinson disease, a history.
This episode was powered by Paul Hodge, a financial planner who works specifically with medical professionals. He has helped members of the BrainWaves podcast grow their wealth and manage risk. Learn more about how to secure your financial future at paul-hodge.com.
Although many of the milestones we'll discuss today occurred in the 1960s, we should start in 1884 when a dopaminergic agonist improved the abnormal choreiform movements of a patient with Sydenham's chorea, a disorder wholly unrelated to Parkinson disease, or PD. In this seminal French paper, Wheel suggested that the morphine derivative apomorphine, a non-selective D1 and D2 agonist, could improve Parkinsonian symptoms in the same way it improved the chorea in the post-streptococcal Sydenham's syndrome. Almost 70 years later, in 1950, this was successfully attempted by Schwab and colleagues. However, since the time when James Parkinson described his 6 original cases in 1817, patients received very little physical or pharmacotherapy. A number of patients were treated with the herbal alkaloid Atropa belladonna, otherwise known as the deadly nightshade, whose anticholinergic effects were on occasion safely harnessed by apothecaries like Parkinson to manage the symptoms of his patient's, quote, shaking palsy. Belladonna was also infamous for its purpose as a poison in the Middle Ages. As a side note, some historians credit the origins of toasting with glasses and cups to the premeditated uses of poisons like belladonna. By crashing together goblets during a toast, ale would escape from one container and contaminate the other. So if one mug contained poison, like belladonna for example, this would spill over into the other mug. Nowadays, malignant intentions are less and less an etiology of belladonna poisoning, and the anticholinergic toxicity is more frequently attributed to recreational use or accidental ingestion. That being said, you can imagine the range of toxic side effects from belladonna in patients with PD. So other therapies were explored, but none being quite as popular as neurosurgery. Some of these neurosurgical theories originated following observations that strokes affecting the cortex and subcortical structures improved the abnormal movements in patients with PD and other disorders. The first surgical techniques were pioneered in 1909 when Sir Victor Horsley, one of the designers of the original stereotactic apparatus, resected a woman's precentral gyrus to relieve her hemiathetosis. You may recall that the precentral gyrus also serves as the primary motor cortex, so not surprisingly, the patient was completely cured of her spastic movements. She was also cured of any other movements of that contralateral extremity. She became monoplegic, so the technique was not reattempted, at least until 1937 when 2 other neurosurgeons cured a man of his post-concussive action tremor. In this report by Busey and Case, back in the day when case reports could be 26 pages in length, the surgeons documented,
tremor both at rest and on voluntary movement completely disappeared, and was still absent at the time of the last report, almost 15 months after the operation.
Later on, the authors would state,
there developed a complete right hemiplegia.
The patient's right leg improved significantly, but his arm, to paraphrase the author's description here, became useless.
The movements remained slow and awkward, and discrete fine movements of the hand and fingers did not return.
Various parts of the basal ganglia circuitry were eventually targeted by surgical excision over the next several decades, with variable degrees of success and unacceptably high mortality rates, sometimes upwards of 1 in 5 patients. For example, the internal capsule was lesioned by Browder and colleagues. The globus pallidus internal and external segment were lesioned by Cooper and colleagues. The cerebral peduncles by Walker and colleagues, and many others. For a good image summarizing these neurosurgical sites and the surgeons who targeted them, check out the graphic from Neuroscience to Neurology, which we've also posted on brainwaves.me. Eventually, cryopallidectomy, or surgical ablation of the globus pallidus using extreme cold, became a standard of care, and this is what led us to the present-day 1960s dopamine hypothesis. Anticholinergics like belladonna have also survived into the present-day Parkinsonian pharmacopoeia, but they are more frequently used as adjuncts in younger populations. For more information on the selective utility of medications for PD, you should check out our episode by Dr. Coughlin, which came out only a few weeks ago. At this point in the show, let us welcome our guest to the stage. Cue Levodopa. First isolated from Vicia faba beans in 1910, levodopa was found to be a biologically inert precursor to the highly active catecholamines like dopamine and norepinephrine in 1938. It's hard to imagine nowadays, but at this point in human history, we didn't even know what dopamine did in the brain at the time, or that it even existed in the central nervous system at all. That finding would be delayed another 20 years, until about 1957 when Kathleen Montague would publish her seminal manuscript on rat brains in Nature. That same year, and perhaps the most historic discovery of movement disorders, Arvid Carlsson successfully alleviated Parkinsonian symptoms of animals with pharmacologically induced Parkinsonism using levodopa. Publication of these results would eventually earn him the Nobel Prize half a century later, in fashionable delay as the Nobel Prize Committee is wont to do. But the relationship between dopamine and idiopathic PD still remained a mystery even at this time. Whereas dopamine was found to be in healthy human and rat brains in 1957, the researchers Ehringer and Hornykiewicz found almost no dopamine in the caudate or putamen of cadavers with idiopathic PD. At this point, as you can see, evidence was beginning to suggest that Parkinsonian movements were related to the depletion of central dopamine stores, and could perhaps be improved with the supplementation of this aromatic amino acid. Moving forward with this hypothesis, Ole Hornykiewicz convinced a colleague at the city hospital in Wien Lands to give PD patients small doses of intravenous levodopa, 50 to 150 milligrams. Their findings were unprecedented.
The effect of a single intravenous administration of levodopa was, in short, a complete abolition or substantial relief of akinesia. Bedridden patients who were unable to sit up, patients who could not stand up from a sitting position, and patients who, when standing, could not start walking, performed all these activities after levodopa with ease.
Have you seen the movie Awakenings with Robert De Niro? Yeah, that's basically what happened here. Of course, that movie was based on the earlier 20th century outbreak of von Economos encephalitis, whose etiology is still pretty uncertain. The impressive results by Hornykiewicz and Birkmeyer were published in 1961 in Germany, and subsequently replicated in a variety of Parkinsonian syndromes, like von Economos encephalitis, and while extremely compelling, they were not met without some resistance. A 1964 paper by Magir and Zeldovix demonstrated modest, if any, benefit in Parkinsonian patients who received pretty high doses of levodopa, 1 to 5 grams orally, or 250 to 500 milligrams intravenously. In that study of only 10 patients, 2 showed any objective benefit with levodopa therapy, and 1 patient continued to improve despite crossover into the placebo arm. 2 years later, in 1966, Klaas Feeling published his results of 25 patients randomized in a double-blind fashion to 1.5 milligrams per kilogram intravenous levodopa or placebo. The incidence of subjective and objective improvements in neurologic function were similar between the 2 treatment arms. Rigidity was improved in 9 patients who received L-DOPA, 10 who received placebo. Equal number of patients subjectively felt more agile. Gait was the same, and so on. This study raised a lot of questions, however, because it was a single investigator conducting all of the study by himself, from study design to drug acquisition and administration to monitoring of the patients and reporting the results without any oversight. The drug preparation could have been inadequate or the drug inactivated. The timing or type of evaluations may have been skewed against those typically seen in dopamine-responsive symptoms. The possibilities are endless. It was in this shadow that the landmark trial by George C. Cotzias and colleagues was published, and all doubts were silenced. But Cotzias did not subscribe to the same dopamine depletion hypothesis as many of the prior investigators we've talked about. He thought everyone else had it wrong, and that PD symptoms occurred following depletion of neuromelanin in the substantia nigra. Neuromelanin, as you recall, is the dark staining pigment that makes the, quote, black substance, well, black. According to Cotzias, the known biochemical abnormalities in Parkinson's disease consist of a decrease of melanin pigment in the substantia nigra, and a decrease in some biogenic amines in the substantia nigra and the corpus striatum. Interrelations between melanogenesis and extrapyramidal disease might be of fundamental importance. So, by administering high doses of L-DOPA, Cotzias was implementing a basic concept in chemistry, Le Chatelier's principle. Knowing that levodopa was a molecular precursor to neuromelanin, Cotzias was funneling high doses of levodopa through tyrosine hydroxylase and other enzymes at the substantia nigra to form neuromelanin, which Cotzias knew increased motor unit potentials in cat spinal cord models. To also prove that neuromelanin depletion was responsible for PD, he also peripherally administered melanocyte-stimulating hormone in order to increase central levels of melanin. Unfortunately, MSH produced a symptomatic worsening of these patients' Parkinsonian symptoms, not to mention anticipated skin pigmentation and the unanticipated gastrointestinal consequences. Phenylalanine, a third drug used in the trial by Cotzias, likewise failed to produce any significant benefit, and also had a high adverse event rate. However, levodopa was incredibly effective. At low doses, peripherally administered L-dopa improved Parkinsonian rigidity, and with higher doses, the tremor either improved or entirely disappeared. And these are roughly the same doses we use today in our patients. So Cotzias got it right, but for the wrong reason. Patients weren't getting better because levodopa was being shunted to form neuromelanin. It was being shuttled through dopa decarboxylase to form dopamine, the missing aromatic amino acid responsible for balancing basal ganglia circuitry. Try saying that 5 times fast. The missing aromatic amino acid responsible for balancing basal ganglia circuitry. This finding rapidly ushered in a new era of Parkinson disease treatment, where the use of peripheral dopa decarboxylase inhibitors like carbidopa, dopamine agonists like ropinirole and pramipexole, and monoamine oxidase type B inhibitors like rasagiline and selegiline emerged. Of course, we still use oral therapies pharmacologically related to the deadly nightshade belladonna, drugs like trihexyphenidyl and benztropine, and thousands of patients undergo pallidotomy or deep brain stimulation in the US every year, as we have done in the years preceding Cotzias' original work. But levodopa remains a cornerstone of PD management. It is the manna, it is the spice, and it does not seem to be going anywhere soon. That's all we got for BrainWaves this week. I'm Jim Siegler. We'll see you next time.
Thanks for listening to BrainWaves today. If you like what you just heard, you can find more related material on the web at brainwaves.me or find us on Twitter at brainwavesaudio. Feel free to contact us at bweditorialboard@gmail.com. Be sure to check out our iTunes archive for older episodes. This episode was produced by Jim Siegler. Music by Kai Engel. I'm Erica Mejia. Join us next time for another edition of BrainWaves.